Afternoon and welcome to this special panel session of the OneMed Forum Conference on improving the 510K process, lessons learned from recent benchmarking studies, which is sponsored by the Institute for Health Technology Studies, colloquially known as InHealth. My name is Steve Hallisey, Vice President for Programs at InHealth, and it will be my pleasure to moderate today's event. For those of you who are unfamiliar with InHealth, here are a couple of slides to describe the key characteristics of the Institute, which is a charitable foundation whose mission is to fund research into the social and economic effects of medical technologies. We're governed by an independent board of directors, and our research priorities are guided by an outside research council comprising clinicians, academics, and researchers with strong expertise in medical technologies. We've recently released 2 requests for research proposals focusing on the impact of medical technologies on healthcare delivery systems and on human capital, and the deadline for receipt of those proposals is March 15, 2011. InHealth invests an average of $1 million per year in research, now totaling approximately $14 million since the Institute's inception. The track record of InHealth's investigators has been excellent, resulting in the publication of 18 peer-reviewed articles to date and more in the pipeline. The Institute also invests in educational activities, including an annual summit, which will next convene on April 14, 2011 in Washington, D.C. You can find out more about all of InHealth's activities by visiting our website at www.inhealth.org. This year, InHealth has awarded 4 grants totaling $1.3 million, and the topics are briefly described here. But today, we're brought together by our interest in just one of these projects, which is being conducted by a team led by Jack Linehan of Northwestern University. Jack and his team are working on a comprehensive analysis of the FDA 510K process, industry practice, and the implications for reform. Today's presenters bring a wealth of experience to the discussion of this topic. I'll have more to say about each of the presenters as I introduce them individually, but I encourage you to review the speaker bios that are included in the OneMed Forum conference book. What all of our presenters have in common is their involvement in recent studies of FDA's pre-market notification 510K process, which is the regulatory pathway used most commonly to bring medical technologies to market. In the past few years, that process has come under severe criticism from a variety of sources, and it is now the subject of many proposals for revision, reform, and even replacement. In this session, we'll hear first from each of the presenters about the studies that they've been involved in, and then we'll have a chance to spend some time in a moderated discussion of some of the key issues these studies raise for future regulatory policy. So without further ado, it's my pleasure to introduce our first speaker, Ralph Hall, who has a long industry history in regulatory affairs and is currently a professor and practitioner at the University of Minnesota Law School. Ralph?
Thank you. I'm facing a major challenge. I have 5 minutes to talk, and giving a law school professor 5 minutes is a cruel and unusual punishment. This started more than a year ago when the 510K system was under review, and I was struck by the fact that we really have been lacking data as compared to opinion on whether the system is working and where there are weaknesses and strengths. So I undertook this study. I want to make sure people understand background and disclosures. My primary work is the University of Minnesota Law School. My research was supported by the Kauffman Foundation. I completed academic freedom. I work part-time with the law firm of Baker & Daniels, and I'm also the CEO of a startup medical device company. So there you understand kind of my background and my perspective. This study that I did was intended to look at the effectiveness of the system from a safety perspective, not timing, not efficiency, but safety. And so we reviewed all Class 1 recalls, those are the high-end safety recalls, for a 5-year time period. This is based on publicly available information. Remember that FDA, not industry, is the entity that classifies recalls as Class 1, Class 2, and Class 3. We, among other things, I'm giving you just a brief overview of some of the work we did. There's a lot more that I don't have time for. We analyzed these recalls for the reason for the recall. And we essentially ended up, we had 13 categories that fall into 3 broad buckets. One are pre-submission issues. These can be QSR challenges, failures of design control, for example. These can be clinical information gaps, undiscovered risks, post-market problems, manufacturing, sterilization, etc., and a third bucket, which is not really relevant for us, of the counterfeits and the quack products. If you look at this and understand that the 510K system can only be expected to address pre-submission issues, you see that the majority, 55% round numbers, of recalls are for reasons really not applicable to clinical data or other similar things. These are primarily QSR types of issues. So the majority of our recalls are post-submission problems. When you then break it down, and the data says by the time you combine them, there are roughly 112 relevant recalls, 55% are post-market issues, 7% appear to relate to labeling or clinical issues, and the other 38% are pre-market but QSR type issues. You combine all of this, this indicates that roughly 93% of all recalls are QSR. Why do we care? Well, if you're looking to improve the safety profile of products going through the system, this indicates that the majority of time and effort should be spent on QSR aspects, both pre- and post-market activities, as compared to clinical data. So this reinforces the importance of QSR. We also then took a fast look at how effective the system was in identifying problems. And so we took all recalls for the 5-year time period. We arrived at a normalized denominator, which was the average of 510K submissions over a 10-year period, and tried to calculate the percent of products that had been cleared via the 510K submission that had recalls, Class 1, and those that did not. What you can see is essentially 99.5% of all products cleared did not have a Class 1 recall associated with that product during our study period. If you take that 0.45% and break it down, a little more than half is post-market, the rest is pre-market. Within that, you again see that the majority of issues are in the QSR realm. We did a deeper data dive. We looked at it by product type. We looked at 3-letter product codes, product specialty, etc. This is just one example of that data. And what you see are 2 concentrations of recalls in the cardiovascular space and in the general hospital space. We were interested by some of the areas that had relatively few recalls. For example, you don't see anything in the OBGYN category, very few in orthopedics. And again, we did this in a number of different iterations, including, as I said, 3-letter product codes. When you combine all of this, our data indicates a 99.55% rate of no recalls. And don't take this to too many decimal points, because the denominator is necessarily an amalgamation over multiple years. As I mentioned, it reinforces the importance of QSR. So as we try to improve the system, perhaps we should emphasize that. We also identified a couple of bolus of problems, 2 product types, external defibrillators and infusion pumps accounted for 28% of all recalls during this time frame. We also were unable to identify a clearly definable Class 2B subgroup into which you may think that recalls may have been concentrated. So my 5 minutes are up. We'll have time for questions later on.
Thank you, Ralph. Now it's my pleasure to introduce our next speaker, Dr. William Meisel, who is a well-known expert in and advocate for patient safety, and last year joined FDA as Deputy Director for Science and Chief Scientist at FDA's Center for Devices and Radiological Health.
Well, good afternoon. It's a pleasure to be here and part of this distinguished panel. FDA has been obviously very interested in evaluating the 510K process, and I think it's important as we have this discussion today to keep in mind what the FDA's program is intended to do, and it's intended to meet 2 important public health goals. One is to make safe and effective devices available to consumers as quickly and as safely as possible, and the other is to promote innovation and new developments for patients within the medical device industry. But there were concerns raised about whether the 510K program was meeting these two goals. Concerns certainly among industry about the transparency, the predictability of the FDA, the speed with which we were able to review products, concerns among consumers and patient groups about the safety of the products we were clearing, and concern within the FDA's own ranks regarding some of the staff about the process and the challenges they were facing. So certainly we're very supportive of data-driven analysis and thoughtful consideration of the available data. This shows the number of original 510Ks received by CDRH really over the life of the program beginning in 1976. It peaked in the early 1990s. We currently receive somewhere between 3,000 and 4,000 new 510K applications annually. I was commissioned by the Institute of Medicine to perform an analysis of the available recall data. It's our position that while analysis of Class 1 recalls is certainly helpful and there's a lot of useful information there, it is useful to include Class 2 recalls in the analysis as well. Class 1 recalls are the devices where there's a reasonable probability of serious adverse health consequences or death. Class 2 recalls have a medically reversible adverse health consequence or where the probability of a serious adverse health consequence is remote. And since 2005, among 510K devices, there are more than 1 million device units that have been affected by Class 1 recalls and more than 2 million device units that have been affected by Class 2 recalls. So clearly these are public health issues that warrant our attention. When we look at the annual number of unique 510K applications that are affected by recall, this shows the data for 2003 to 2009. In general, it hovers around 400 a year, so 400 unique 510K applications are affected. That doesn't mean 400 of the ones submitted in 2003. It means 400 of all the 510Ks that have been cleared throughout the history of the program. When we talk about recall-free survival, if you will, in other words, what are the percentage of 510K applications that are on the market and have not experienced a recall? If we look at the cohort from 2003 to 2009, this shows the survival. And if you look at the numbers down next to the survival, so at year 0, all of them are still on the market. By the first year, 98.4% are still on the market without experiencing a recall, or 1.6% did experience a recall. So over time, obviously more and more devices are going to experience recalls, and by about 5 years after being on the market, slightly more than 7% of 510K applications have experienced or been affected by a recall. Now, certainly not all of these recalls have major serious adverse health consequences, and it's important to keep that in mind.